Uh, Good afternoon, everybody. It's a pleasure to be here. Thanks. I would like to thank the organizing committee for inviting me to speak in this prestigious meeting in Cairo, a city that's very dear to me. It's great to be here in the presence of my mentor, Dr. Kaplan, and my postdoc, Dr. Khalifa, who's defending his thesis tomorrow. It's a real pleasure to be here. So I'll be talking about mesenchymal stem cell role in modulation of the response to injury and stress-urinary incontinence models. Why am I interested in injury models for urinary incontinence? To give you some background, I'm a practicing female urologist. So I do exclusively female urology back home at Cleveland University Hospital. And my interest is in treating this condition of female urinary incontinence, which we believe is a result of mostly the injury that a woman receives in her younger life during childbirth injury. So, and I do believe that the incontinence that happens in the lifetime of a woman is a result of a balance of two things. One is the injuries, and the second factor is the recovery mechanism. So when the woman gives birth, the pelvic floor and the continence mechanism receives a big trauma. And the end result of incontinence depends on the recovery mechanism that woman has to avoid this trauma. So this is best put in the integral lifespan model by John Delancey, who you guys know if you follow the female pelvic floor literature. He's an authority at University of Michigan. So he put together this model, which I really, it's inspiring because it puts my work into a visual. Is this, can we, no pointer? Okay. So if you look at this model, the first model here, it doesn't work. The first panel is the development of the pelvic floor health in a female patient during her lifespan. So as the female grows, the pelvic floor health is increased. And then during the life phase of a female patient, there is the most inciting factor, which is the childbirth injury, results in a dip in this continence mechanism. And typically, if you don't recover that continence injury, and you will develop stress incontinence that is clinical early in life. So is that working now? Okay, so if you look at this graph here, if this is the threshold for urinary incontinence, if you do develop an injury that's severe enough that you don't recover early on after delivering babies, then you will have stress urinary incontinence that's clinical in your 20s and your 30s, and you'll come seeking help for incontinence treatment. If you partially recover, then you will meet the baseline later in life in your 50s or 60s. Now, the challenge would be, depending upon your genetic makeup, you might not have enough strength in your pelvic floor because of the weakness of your collagen genetically. So if you develop a trauma or repeated trauma with repeated childbirth, then you'll meet that threshold line early in life. So the whole idea of our research is how can we improve on recovery? How can we augment the recovery so we can push that line back to normal? So, and recovery is seen in a number of epidemiological data. It's not only a theory, it's based also on some epidemiology. This is the numbers that you see in the Victrop trial in Europe. He recruited women and followed them throughout pregnancy until they delivered and a year after they delivered. And you can see that stress incontinence was almost a third of pregnant women. 1/3 of women had stress incontinence during pregnancy. What happens is that they deliver babies, and at 3 months after delivery, only 6% has stress incontinence. So these women were able to heal their pelvic floor after they delivered. Yet, if you follow them up for 5 years, the stress incontinence came back to 30%. What's more important is the next graph. If you look here, these are the women who did not recover at 3 months. So if you are a female patient who delivered a baby and you have stress incontinence immediately after delivery, but you don't recover the incontinence at 3 months, there is a 92% chance that you will have stress incontinence later in life. which is pretty significant. And this is the opportunity we look at. This is where I believe stem cell therapy is going to help. If we identify the patients who are at risk, whether because of we characterize them, identify the risk factors, and intervene at the time after delivery while their active healing process with stem cell therapy, then we can help them. So how can we take this full circle? So we go back to the lab. In the lab, there is a model. So this is the theory. We want to push this baseline. We want to push this curve back here so that we improve on the recovery and delay the occurrence of stress incontinence. Now, in the lab, we have the capability of using a model called the vaginal distension model. Vaginal distension model in the rat allows us to distend the vagina of the rat with a balloon, simulating the childbirth injury. Okay? What happens with that injury is that there will be a dip in continence. So this is the baseline. We call it leak point pressure, which is the measurement of continence in the sphincter. If you do the vaginal distension, you will have a dip in continence at 4 days, and then there is a spontaneous recovery, which is the natural recovery. So that model we can use to simulate human condition. So because of the ability of this model to spontaneously recover, it yields itself to stem cell therapy and testing. So what we did in this experiment, and this is my first experiment here on direct stem cell therapy, which we collaborated with Dr. Kaplan on, we injected mesenchymal stem cell, human mesenchymal stem cells directly after vaginal distension injury. And we saw that the locally injected mesenchymal stem cells resulted in an accelerated recovery within 4 days. So at 4 days, when you see typically a dip in continence, it recovered immediately after you give them the stem cell therapy. And this recovery was specific to the mesenchymal stem cells. So it's not any cell can do that recovery. It's the mesenchymal stem cell that yielded that recovery. Because if we inject mesenchymal fibroblast, like you see here, there was no improvement in continence. So it's not a bulking effect, because we did inject fibroblast instead of mesenchymal stem cells, and we didn't see a recovery. This is a picture of the stem cells we injected. This is the vagina, this is the urethra, and this is the stem cells at 24 hours. You see that they come together. They are concentrated in the area of injury because of certain chemokines we'll talk about. Now, when we followed these stem cells serially over time, initially we thought when we inject stem cells, they will go sit there and start regenerating and building sphincters. To our surprise, when we followed them up over 7 days, we saw that at 3 days, the stem cells are there, but at 7 days, they're gone. And if we inject the stem cells without injury, so if you just go and inject stem cells into the sphincter of the urethra without causing an injury, you will see the stem cells in the lungs immediately. And this phenomena is because of the homing factors that the injury releases that will allow the stem cells to stick around. So mesenchymal stem cell locally injected home, proliferate, exert their effect, but are gone within 7 days. So most likely, this led us to the theories that Dr. Kaplan talked about. Dr. Kaplan likes to call the mesenchymal stem as the drug delivery vehicle. So when you put the stem cells in the injury milieu, they release chemokines, and these chemokines are important in fixing the milieu. And we will talk about that later.